Good afternoon, everyone. Good morning, good afternoon, depending on where you are. I am Darren Orbach from Neurointerventional Radiology, and joining me today are going to be Christopher Isibor and Jen Judge, our Cerebrovascular NPs, and Dr. Soliman Oushy, who's our Cerebrovascular Fellow. And we're going to talk about fetal embolization for vein of Galen malformation. Let me share my screen. We will have ample time for questions and answers, so I will ask that if you have questions during the talk, please type them into the Q&A section, and then Jen, Christopher, and Soliman will collect them, and they will ask the questions afterwards and either address them themselves or we'll address them together as needed. If you asked a question and you feel that it was not addressed fully, please let us know, and we'll circle back and continue the answer beyond that. So once again, the topic is fetal embolization for vein of Galen malformation. And let me just jump right in and get started. So I have no financial disclosures or conflicts of interest. And the first question is, why contemplate something like fetal embolization for vein of Galen malformation in the first place? And the answer is that pretty uniquely among all central nervous system vascular lesions that we deal with, vein of Galen malformation really sustains massive amounts of flow and therefore has catastrophic systemic impact. Usually in the world of neuro, we're worried about the brain, but not so much about systemic effects. But for vein of Galen malformation, you have right and left ventricular output that can be 2 to 3 times normal, massive SVC return to the heart, and you have over 80% of the total cardiac output passing through the malformation. And the result of that has been really nicely elaborated in the last few years. Largely based on some studies out of Great Ormond Street Hospital, where because of nationalized healthcare, they are able to collect all of their cases and get national level data. So they found that about 2/3 of the babies with vein of Galen malformation fall into this category of neonatal at risk, or NAR. These are the ones who get very sick in the NICU. They develop heart and lung failure. They have multiple high-risk embolizations right after birth. In this cohort, even at an expert center like Great Ormond Street Hospital, there's a 30 to 40% mortality. And maybe even worse than that, of the survivors, about 50% have severe neurocognitive compromise. So very high risk situation for about 2/3 of all the vein of Galen newborns, even when treated at an expert center. If you put all those numbers together, there's only about a 30% likelihood for the baby in this cohort to get to adulthood without significant neurological injury. The other 1/3 of the patients they found do not develop these severe symptoms at birth. They do typically undergo elective embolization at 6 months. And they have a much better survival rate, of course, close to 90%. And it's not a free pass in that cohort either. So 30% of them do have poor neurologic outcome, but of course, a much better outcome than the babies who get sick at birth. And this research has been extended in the last few years. So there have been a bunch of studies looking at, from the fetus's perspective, what's the prognosis for vein of Galen malformation? This was a nice meta-analysis that was published in 2022. And they found that if you add together the intrauterine deaths, the neonatal deaths, you get a perinatal death rate of almost 25%, an infant death rate of 3.5%. So you have about a 28% mortality rate under the age of 1 year. Another 37% of them have an abnormal neurodevelopmental outcome. So again, the numbers add up to about a 1/3 of the fetuses with this condition are going to end up in good neurologic shape, surviving and in good neurologic shape, even when treated at expert centers. And here are just some examples we've seen here in the last few years. This is a 2-week-old brain MRI 2 weeks after birth. You can see massive bihemispheric injuries, tremendous loss of cerebral tissue. There's nothing we could possibly do to intervene to give this child a good neurologic outcome. Here's another patient, 1 day old at birth, the scan, and you can see there are basically no cerebral hemispheres to speak of at all. Here is a dramatic case from a few years back. This was the scan that was obtained locally, and you can see there are some brain injuries bihemispherically already on day 1, but we thought there was enough intact brain parenchyma to offer treatment, and this child was med-flighted to us. We repeated a scan before doing any treatment at all, and by day 9, you can see what's happened, basically gliosis and injury to the entirety of both hemispheres. So it's extremely unlikely that anything we could have done after birth would have resulted in a different outcome. On top of that, these procedures that we have for urgent embolization after birth are very, very high risk. This was a beautiful paper out of Toronto Sick Kids, which is really one of the world centers for managing vein of Galen malformation after birth. And they found when they looked at their own experience that they had a 30% major procedural morbidity. So this is not natural history. This is directly related to the embolization. Half of those patients died. So a 15% procedural mortality at a world-class expert center. So if you ask, honestly, how are we really doing in managing this condition? From the perspective of the pregnant parents, the chances of a tragic outcome really outweigh all other chances for all other outcomes. So I want to pause here and make an observation and then talk about two compelling physiologic factors that induced us to look at this differently. So the observation is that in utero, the heart and the brain of fetuses with this malformation seem to be protected. So they all have increased cardiac output, they all have big hearts, but to actually have heart failure in utero is quite rare. Whereas postnatally, high output heart failure is actually common. Similarly, brain injuries in utero do happen, but they're actually rare, and they typically are a postnatal phenomenon. Let me give you an example of that. This was a case from just 2 months ago here. This is the fetal scan on a patient with a vein of Galen malformation. This is the diffusion-weighted imaging that shows acute stroke, and there's nothing. The brain parenchyma is intact on this scan on March 5th. And then this is the fetal echo. And you can see certainly it's a big heart. There is increased cardiac output, but the ventricular function was normal in utero. And now the baby was born 3 days later, and look what happens. The postnatal day 1 echocardiogram, you now have immediately moderate systolic dysfunction on the right side. You still have normal left ventricular function, elevated BNP, of course, but devastatingly, look at the brain MRI. First MRI after birth, nothing's been done. Natural history of the malformation, massive stroke of the left hemisphere, just from the act of birth, and we'll talk about why that happens in a second. Look at the echocardiogram deteriorating. Now you have moderate to severe RV dysfunction. A day later, now you have some LV dysfunction as well. So for that reason, we did embolization the next day. And you can see that the echo, the heart function responded very nicely. So the dysfunction is improving in both ventricles. But look at the scan. You have extension of the infarct to the right hemisphere now through the corpus callosum and new dots of diffusion artifact, a diffusion restriction on the right side. So you have progression of ischemic insult, and this baby, and some brainstem injury as well. And the parents elected to opt for palliative care at that point. So again, in utero, the brain and the heart seem to be protected, but postnatally, they have this very aggressive presentation of heart failure and brain injuries. So almost certainly the protective effect in utero is due to the presence of the placenta. As you all know, the placenta is a massive low resistance, high flow vascular organ. It carries about 45% of the combined ventricular output, and it acts as a sump. And then when you lose the placenta at birth, that entire high flow of the malformation is immediately put onto the newborn's heart and brain. Additionally, an interesting fact about normal newborn brain physiology is that fetal brain blood flow in general is far lower than neonatal blood flow. We know that the blood flow through gestation increases throughout gestation. And then after birth, there is a massive increase in normal cerebral blood flow in the first day to 2 days of life after birth. And intriguingly, this really corresponds to the time when most of the decompensation starts to happen. They're usually okay on day 1, and it's really day 2, day 3 that they start to deteriorate. So there's lots of literature on this increase in postnatal blood flow to the brain. This is just one example of a paper. This is using ultrasound. This is anterior cerebral artery flow 1 to 2 hours after birth. You can see what the rate is over here. And then 24 to 48 hours, there's a doubling of anterior cerebral artery flow. These are normal newborns. So the brain is expecting a massive, massive increase in physiologic blood flow in the first 24 to 48 hours after birth. This has also been documented with perfusion MR, and you can see continuous increase in cerebral blood flow through gestation. And then at term, there's an even increased, massive increase in flow. That actually continues through childhood till about age 8, and then cerebral blood flow starts to decline and then levels off in adolescence. So that raises the question, should we be thinking instead of fetal interventions? Maybe this paradigm that we have of in this condition, having the baby being born, experience the loss of the placenta, and then have this terrible compensation, and then try to overcome that is just all wrong. And what if we can circumvent this aggressive pathophysiology altogether using the protective environment of the placenta and the fact that the brain is not expecting these high levels of blood flow in utero in the first place. So the first thing is we have to identify the right fetal cohort in which to do this. I mentioned there are several possible cohorts. So the first one are the babies who do well postnatally, right? Those are the ones who we watch in the NICU, we send home and then bring them back for elective treatment. They are definitely not appropriate for fetal intervention. On the flip side, there are those rare cases who already have parenchymal brain injuries in utero, and they're going to have a terrible neurologic outcome regardless of what we do. They're also not appropriate. So we're looking for most of the cases who have intact brain parenchyma but are at very high risk for decompensation after birth. That's the NAR cohort that I showed you before. And the question is, can we predict who is in that cohort based on a fetal scan? And the answer is absolutely we can. This was the first part of this project. We looked at basically every morphologic feature on fetal MRI that you can measure, and we asked which of these features correlates to the clinical outcome of the baby after birth. We found that lots of them loosely correlated, but one particular measure beautifully predicted how the baby would do, and that is the width of the falcine sinus that drains the malformation. So here's a sagittal view. Here's the main venous varix of the malformation, and then this is the falcine sinus draining the blood flow back to the torcular and back to the internal jugular veins. The width of this sinus here, you can see in a coronal view, is a beautiful measure of blood flow returned to the systemic circulation. And here you can see as the width of that sinus goes up, the probability that that fetus is going to end up in crisis in the NICU goes up dramatically. When you get to a 7-millimeter width, there's an 80% likelihood that fetus is going to end up in heart failure intubated postnatally. So this was terrific on its own. This allowed us to change the kind of conversation we had with parents prenatally, because before this, there was this incredible range of possible outcomes, from fantastic outcomes to death in a few days, and we had no way of predicting that. Now we can at least set psychologically some expectations for the parents. It also allowed us to identify an appropriate cohort for trying a new fetal intervention. So what is feasible fetally? As you all probably know, the least invasive fetal intervention we have, surgical intervention, are ultrasound-guided needle-based fetal cardiac interventions that have really been pioneered here at Brigham and Women's Hospital and Children's Hospital over the last 2 decades. Here you can see a trocar going through the fetal chest and into the left ventricle. This is to prevent hypoplastic left heart syndrome from aortic stenosis. Here you can see the wire passing through the aortic valve. So if you see this and you see there's a whole multidisciplinary group already put together to do these fetal interventions in a safe way, it begs the question, can we do something similar for vein of Galen malformation, to access the malformation with a needle via ultrasound guidance in the same way through the occipital bone, introduce a microcatheter, and then coil the malformation, not to close it completely, but to dramatically diminish the flow. So how do we design this? There are unfortunately no animal models that even remotely resemble vein of Galen malformation. So instead, we had our simulations group design fetal brain phantoms for us made out of cryogel. Cryogel looks just like the brain on ultrasound. And we had them design cryogel phantoms based on actual fetal scans of patients of ours. So here you can see the big vein in the middle with a draining sinus. We did a pre-op MRI scan. And then here you can see my MFM colleagues' hands doing the ultrasound-guided needle access. And here is what the images look like. This was an open question to us because all neurointerventional devices are designed to be used under fluoroscopy, not ultrasound. So we had no idea what the visualization would be like. And here you can see the wire entering the varix. Here you can see what coiling looks like, quite visible. And here you can see progressive coiling, an early coil, a middle coil, and a later coil with increased posterior shadowing as you increase the density of the coil mass. This is the post-treatment MRI scan of the phantom, and then we opened it up to verify that we did, in fact, deposit the coils at the target zone in the varix and not in the falcine sinus. We also had the simulations group design for us sample fetal cranial bone little pledgets so that we could practice manually drilling through in a very controlled way. There's a wide variety of mineralization of the fetal bone. It's actually very hard to predict. So we had them design increasing thickness and hardness so we could practice with different levels of bone. And putting all that together allowed us to get FDA and IRB approval to launch a formal clinical trial of fetal embolization. And it's a safety and efficacy trial. I'll just say quickly, the efficacy is defined as the baby is born and then does not crash in the NICU. So the baby does not get intubated, does not go into heart failure, does not need urgent fetal embolization. We're trying to convert them from that NAR cohort to the IT cohort, to the elective treatment cohort. And then it was a matter of waiting for our first patient, and here was our first patient. So back last February in 2023, 36-year-old mom picked up at 30-week routine ultrasound. You can see big malformation on color Doppler. She underwent an MRI scan and then was referred to us for further evaluation. Here's the first scan that was done at 32 weeks. You can see the big venous varix. The falcine sinus already measures 11 millimeters, very wide. You remember there was a 7 millimeter cutoff for inclusion. This is that chart I showed you. At 11 millimeters, there's a 98% probability this baby is going to crash. So one of the most aggressive malformations we had seen. They came to Boston for fetal embolization. By the time we repeated the scan at 34 weeks, the width of the falcine sinus was now 13 millimeters, so almost literally off the chart. Near certainty this baby was going to do badly, but the brain parenchyma was intact at the time. So we took her to the OR last March 15th, 34 weeks and 2 days. And here's what the embolization looked like. And you can see just how well the phantom predicted what the appearance would be. So here's the needle going through the occipital bone. Here's the wire entering the varix. And then here's progressive coiling, early coil, middle coil, later coil with increasing shadowing as it goes. And we were able to convert the malformation from this appearance with huge flow in the varix and in the falcine sinus to just coil mass in the varix and really drop out of flow posteriorly. This is what the setup looked like. And we saw an immediate impact on the fetal echocardiogram. So here's the pre-op echo and the post-op echo. You can see a 40% reduction in combined cardiac output the day after the procedure. Most of that was drop in right ventricular output, as you would predict. And then it was also reflected on the fetal MRI scan. You can see that the falcine sinus went from 13 millimeters pre to 8 millimeters post. And actually the whole malformation started to come down inside. Much to my chagrin, mom actually had premature rupture of membranes and the baby was born only 2 days later. At the time, I thought that the pregnancy would need to continue in order to have a good effect. But we had to deliver the baby and it turns out the baby was completely fine. So very much unlike any other vein of Galen baby we have had in the NICU. Here you can see the puncture site on the scalp. Basically, the baby needed no cardiovascular support during the NICU stay, no medications other than antibiotics for the ruptured membranes, no postnatal, neonatal endovascular interventions, really just sitting there on a nasal cannula. And we essentially watched the echocardiogram improve over the first few weeks without any intervention. Here's what the brain scan, the MRI scan looked like on day 26, just before we discharged her from the NICU. This was her at discharge from the NICU. We wrote this up in Stroke last June, and it was published there. And then we continued to follow her. Of course, we're following all of them for a long time. This was the scan at 3.5 months. You can see continued compaction of the coil mass. There still was some flow in the malformation. She's been here since for elective embolization with now no detectable residual flow. This was her at 4 months and 10 months, completely neurologically intact. She's now 8 months old. I'm sorry, she's now 13 or 14 months old and completely intact. This was our second fetal patient who was embolized in September, last September at 35 weeks and 6 days. Similar story, almost 9 millimeter falcine sinus. After embolization went down to 7 millimeters. This mom did not have premature rupture of membranes, went into spontaneous labor at 37 weeks. Again, no neonatal embolization, no intubation. This baby did need some Lasix for support, but that was it. The echocardiogram showed pulmonary pressures to be suprasystemic at birth and then systemic at day 2, half systemic by day 5. Again, no embolization. We just watched the echo improve. Similarly, the BNP, we watched it go down without any treatment. This baby underwent non-urgent embolization at 7 weeks for an increase in ventricular size on surveillance head ultrasound, which is something we see in the elective cases also when we send babies home from the NICU after they're doing well. This baby is now 8 months old, neurologically intact and doing great as well. This was the scan on postnatal day 11. Again, you can see intact brain parenchyma. Third patient was embolized just last week. Very wide malformation. Again, you can see 12 millimeter falcine sinus. This baby was embolized at 33 weeks, 6 days, a little earlier than we would like to, but there was polyhydramnios and some early fluid collections. We were worried that this was headed towards heart failure in utero. We got a very good packing density, no appreciable fetal or maternal procedural morbidity. Mom was discharged the next day after the procedure. And here's the fetal echo, and you can see a dramatic drop again in cardiac output, almost 50% from pre-procedure to post-procedure. Same thing with indexed combined cardiac output. Fourth patient embolized. Again, very big malformation, 13 millimeter falcine sinus, This embolization was at 36 weeks and 1 day. This patient came here from Mexico for embolization. Again, excellent packing density. Again, no appreciable fetal or maternal procedural morbidity. Mom was again discharged the next morning. Again, a major drop in combined cardiac output, which is not at all what you ever see in the natural history. The cardiac output just goes up. In these malformations, it never comes down like this. So this is clearly a strong treatment effect. Neither of those, one of those two babies was literally just born an hour ago. So far doing well, but I don't know any more details. The other baby's not yet born. They were both treated very recently. There's one more case outside Boston Children's I want to mention. This was a baby in Paris. EV had heard me give a talk on this years ago and was excited to do this procedure as well. And they had a case that qualified well based on our criteria. And they did a fetal embolization using the same kind of procedure. And then that baby did very well, did need 1 round of embolization in the NICU, and then came back for 1 round of infantile embolization at 2 months of age. And now over 12 months, actually, the baby is now 16 months, I think, normal MRI scan, normal exam. This was written up and published a few months back in the American Journal of Obstetrics and Gynecology. And I just want to end with just a little bit of an ethical consideration on where this should be done. I actually am aware of several attempted embolizations, fetal embolizations based on this approach in several continents. At centers where vein of Galen malformation is really never managed postnatally, so they just don't have the requisite expertise in the NICU or on the neurointerventional side, neurosurgical side, and the cardiology side as well. And the result was uniformly dismal in all the cases that I'm aware of. I just want to show one case. This case was actually referred to us for treatment. Here's the fetal scan. There's already major bihemispheric injury here. You can see loss of the gray-white matter and feathering of the contour of the cortex here. Really diffusely throughout both hemispheres. This is a diffusion-weighted image, and you can see there are major strokes in both hemispheres already. We told them this patient was not an appropriate candidate. This is that severe fetal presentation scenario, and they went ahead and embolized anyway with a catastrophic outcome. So just to conclude, the current standard of care paradigm where we have the babies be born and then do these neonatal interventions certainly was a triumph at the time. Vein of Galen malformation used to be nearly uniformly fatal, and it's not that. But even with standard of care, there really is a very high fraction of patients who we are not helping, and there's still severe morbidity and mortality, even when treated at expert centers. There likely are significant advantages to reducing malformation flow in utero before you get this aggressive physiologic cascade that starts when you lose the placenta. The safety and efficacy of fetal embolization have yet to be determined, but based on our very early results, the morbidity appears to be low. The efficacy looks like it's excellent. I really cannot overstate the importance of completing a rigorous trial before disseminating this to other centers. I think it's so important to do the science and actually demonstrate safety and efficacy. I will say that fetal intervention here as part of the trial is actually paid for by research funds, so there's no expense to the patients for getting here and doing the fetal intervention. Let me stop there, and thank you all for your attention. And as I said, I'm happy to take questions. Any questions? I will, I'll just say one thing that people do frequently ask is what is the gestational window for the intervention? And we have kept it deliberately wide. So really it's anytime, theoretically, anytime from diagnosis to term. We have started favoring the time between 33 to 36 weeks as a time where it's not, the baby's not too premature if there is early delivery at that point. but it really needs to be tailored to the individual pregnancy and the individual situation. So it's a fairly wide window. If you do have patients you'd like to refer, please refer them as early as possible, and we can discuss with the patients and with the caregivers when an appropriate window for intervening would be. All right. If there are no other questions, I will wrap it up then. Thank you all for your attention.